You had mentioned them briefly in terms of the classifications of different types of Alzheimer's. I don't think people recognize or realize that there's not just one etiology. It's not just, uh, you know, I mean, I know that there's been a lot of talk around calling Alzheimer's type 3 diabetes, and we can talk about that. In your book, you talk about that sort of type 1.5, that glycotoxic classification. But can you unpack for us the different types of classifications of the disease and where it comes from?
Yeah, that's a really good point. And that's been one of the issues is, people say, well, why did this person get it when they're 48 and this person got it when they're 78? And, what's the difference? They don't look the same. They don't have similar numbers. What's the deal here? They don't have similar, genetics. They don't have similar biochemistry. So why did these people both get, quote, the same disease? Well, so as we started studying this and looking at how does this molecular switch in the middle work, APP? And I should add, by the way, people initially said, oh, great, just prevent the switch from going the bad way. Well, guess what? Your body's not that stupid.
Right.
It finds ways, if you're trying to protect yourself, it finds other ways. So it's not that simple. This is why one drug hasn't worked. You need a personalized precision medicine protocol. So the bottom line here is when we started looking at people's profiles, genetics, and biochemistry, we started to see, oh, wait a minute, they actually sort into different groups. So there will be people whose primary driver of this APP being on the wrong side of the balance, literally you're talking about synaptoblastic making synapses versus synaptoclastic pulling back on the synapses, much like you'd talk about osteoporosis as being an imbalance between osteoblastic and osteoclastic signaling. This is a difference, an imbalance between synaptoblastic and synaptoclastic signaling. When we started to look at these people, we saw one group that was predominantly inflammatory. So they have high HSCRPs, they often have high interleukin 6, TNF alpha, things like this. They're on fire. And that can be from leaky gut, which is a common one. It can be from chronic sinusitis. It can be from metabolic syndrome, on and on. But that's their predominant problem. So you need to find out what's causing that inflammation. We hear so much about, oh, we should all be taking anti-inflammatories. Well, we should also understand, why are we inflamed? What's actually doing this? Because this is about getting to the root cause. There's 21st century medicine is really about one word, which is why. Why did this happen? You want to go as upstream as possible and keep asking why until you understand what went wrong. Then we found a separate group of people, and I should say the inflammatory people we call type 1 or hot or inflammatory Alzheimer's. And then type 2 is atrophic. These are people that are typically a little older. They just don't have enough support from hormones, growth factors, or nutrients to support a large neural network. So if you literally add back, you optimize the support, they do much better. And then, as you mentioned, we have one we call type 1.5, which is the glycotoxic. And the reason we called it that is because it has features of both. As you indicated earlier, the glucose actually gets stuck. It's a non-enzymatic sticking. It's like remoras on a shark. You stick onto multiple proteins, and we measure it, of course, as hemoglobin A1C, but there are lots and lots of other proteins. It alters their function, and it alters their antigenicity. So now you get an inflammatory state responding to this, quote, abnormal protein.
Mhm.
But in addition, you also, because of the high insulin, respond poorly to insulin signaling. And insulin is one of the most important growth factors in your brain. And therefore, when you're no longer responding to that, you don't get the support for your brain that you did. So you have both features of inflammation and features of an atrophic response. So that's why it's type 1.5 or glycotoxic or sweet Alzheimer's. And so you mentioned earlier so-called type 3 diabetes. Yes, that's certainly relevant for Alzheimer's, but as you can see, there's more to Alzheimer's than just that.
Mhm.
Then the type 3 people, we initially didn't know about them, and we started having people who were failing on the treatment of the other things, of the glycotoxicity, the inflammation, and the trophic loss. And we wondered, who are these people? What's going on here? And I actually started calling the spouses and started to talk about what happened in their childhoods and what happened. And we realized these were people who had very high toxic exposures or were very poor at dealing with toxic exposures. And this, as I mentioned earlier, can be metals like mercury, can be organics, and it can be things like propylene oxide or formaldehyde or toluene, people who've been lots of exposure to paraffin candle burning, for example, people too much exposure to chemical factories. We had the question recently about whether even too much exposure to things like laser, being very close to laser printers. This is all still being worked out. We'll see. But these are things that had never been considered before. We just say, oh, it's Alzheimer's. We don't know what's causing it, which makes no sense. We're now beginning to understand the various contributors. And then, of course, a big one that surprised me was mycotoxins, people who live around specific species of molds. And it's not all molds. So there are a lot of molds that aren't making these mycotoxins, or there are a lot of people that aren't responding. But about a quarter of the population, as Dr. Richie Shoemaker has pointed out for years, tend to be quite sensitive to these things. And these can be things like trichothecenes or aflatoxin or ochratoxin A. These are toxins that are quite bad for your body. And when you respond to them, you develop an inflammatory state. You activate your innate immune system, the evolutionarily older part of your immune system. But interestingly, they are also immunosuppressive. So you're not so good at activating the adaptive system. So you live with this chronic activation for years and years, and you ultimately damage your brain. And by the way, the amyloid that we talk about in Alzheimer's is part of the innate immune system. So anything that gives you a chronic inflammatory state is going to have you making this amyloid and downsizing over the years. So that's what we call type 3 or toxic Alzheimer's. And then type 4 is vascular, people who have poor vascular support. And this includes, by the way, people who have poor oxygenation at night. So I recommend anybody who is concerned about cognitive decline or is experiencing some cognitive decline, please make sure to check your nocturnal oximetry. You can get a sleep study, that's fine, or just borrow from your doctor or buy one yourself, a little oximeter, stick it on your finger overnight and check to see where you stand. Because if you're dropping down, you should be in the 96 to 98% saturation while you're sleeping at night. And we have people dropping into the low 70s, which is really scary. And these people are contributing to their own cognitive decline without knowing it, and their doctors aren't typically checking it. And then the last one, type 5, is traumatic. So if you have a history of head trauma, whether it's from playing football, whether it's from many headings of the ball with soccer, all these things have been shown. Traffic accidents, what have you, they increase your risk for cognitive decline.